Good afternoon. Welcome and regards from Urology Clinic. I'm Dr. Abhay Kumar, consultant uro-oncologist, urologist, and robotic surgeon in Narayana hospitals. And one of the common cancers that I deal is bladder cancer. In fact, this is the most common cancer in urology cancers OPD in my hospital setup. And good thing about bladder cancer is many of bladder cancer patients are in the early stages, or what we call as technically as non-muscle invasive bladder cancer or superficial bladder cancer patients. And one of the most important treatment modalities for superficial kind of non-muscle invasive bladder cancers is a regular cystoscopy and initial surgery, endoscopic surgery called TURBT, that is transurethral resection of bladder tumor. And depending on the biopsy report, uh, if it is a low grade of superficial bladder cancer, then the treatment remains just a cystoscopy or surveillance cystoscopies, nothing much is required. But if it is a high grade kind of non-muscle invasive bladder cancer or a superficial bladder cancer which is high grade in pathology, then these kind of tumors require some additional therapies. And the additional therapies are like intravesical chemotherapies or immunotherapy like BCG. So there are a lot of questions regarding why this intravesical therapy is done, why we need to come every week and put a medicine or BCG in the bladder. So there are a lot of questions and it's difficult to answer in my routine regular OPD, and that's why I thought of having this session because despite trying to make the patient understand, a lot of time I feel there are a lot of questions which remain unanswered or unattended. So देखो ये when there is superficial bladder cancer, there is chances of recurrence and progression. Means once this tumor has been removed by endoscopy, that is not the end of the treatment. If your biopsy report says it's a superficial bladder cancer or a non-muscle invasive bladder cancer, but it's a high grade, then the chances of this disease coming back again and again, what we call as recurrence, is very high. And depending on this risk, that how much is the risk of this disease coming back again and again, we have divided the superficial bladder cancers into a low risk or a intermediate risk or a high risk group. So the patients who have high grade bladder cancer are in the high risk of recurrence. So that is the chances of the disease coming back again is very high. And there are certain ways to decrease this recurrence or the risk of recurrence, and one of them is putting some medicines in the bladder. So most important is the first surgery, that is the TURBT, which has to be done by someone who is experienced and doing it regularly. And sometimes we have to redo the initial surgery, what we call as technically as restaging TURBT. That is, we have to go again in the bladder and remove the base of the tumor again and see whether there is any disease going into the deeper layers of the bladder or not. And if it is confirmed that we are dealing with a high grade but superficial bladder cancer, then we need to do some additional treatment. So the options are either a usually some chemotherapy like mitomycin C or gemcitabine, or a more commonly used agent called BCG. The vaccine which was used for preventing TB, the BCG which is given in the childhood or early childhood in the children, the same vaccine in some other form is used to prevent the recurrence of bladder cancer in bladder cancer patients. So we use it as a local immunotherapy. That is, the role of BCG is to create some local immune response in the bladder to decrease the chance of recurrence or disease progression of bladder cancer. And this BCG is directly put into the urinary bladder. So it is not injected in any body part, but directly through the urinary passage. We put a small catheter and directly uh, uh, put the BCG medicine inside the urinary bladder to create a local immune response. So depending on the your disease profile, this therapy can be started after 4 weeks. Usually, I start by 4 to 6 weeks of initial surgery, that is TURBT, so that the tumor base heals by the time we start putting this medicine in the bladder. Because if you start putting it earlier, there may be very high chances of what do you call it, response, allergic response, or local reaction, which is unsuitable for the patient. So 4 to 6 is the time when we start putting BCG, and there is a protocol depending on what your institute prefers. So either a 80 milligram dose or 120 milligram dose, and sometimes when the patient is not tolerating, we can decrease further to 40 milligram dose of BCG, which is put in the urinary bladder once in a week for at least 6 weeks initially, what we call as a induction course, and this is followed by a regular cystoscopy after 3 months from the date of surgery, and depending on the risk, we continue the BCG for 3 more doses at the interval of 3 months, what we call as a maintenance therapy. So 1 year to 3 years is the usual course of BCG, 3 monthly, three doses maintenance therapy, depending on whether you are in the intermediate risk or high risk group of recurrence. So usually it's a not a very painful procedure. The patient comes to the OPD, and after consultation, I inquire the general health condition, and in the OPD side room or OPD procedure room, we take the patient and ask the patient to pass the urine and empty the bladder, and we ask the patients not to consume any fluids or drinks, and any diuretic like tea, coffee, and anything like that at least 2 to 3 hours before the procedure, so that whatever medicine we put in the bladder, that remains there for a longer period of time. And uh, we put the BCG in the bladder directly by putting a small catheter, and after putting the medicine through the catheter inside the bladder, we take out the catheter and ask the patient to hold the urine for some time, ideally around 1 to 2 hours, and then pass the urine. Usually it's a very what do you call, painless procedure, but sometimes the patients may have some difficulty if there is any problem in the urinary passage, or if there is previous reactions to the BCG, or if there is big prostate. Otherwise, there's not much of problem, and we give us a short course of antibiotics and painkillers. And if sometimes the patient has some prostate issues or some bladder issues, then we give some other medicines to decrease the symptoms of the urinary system of prostate and bladder. And we ask the patient to pass the urine in a commode and flush it nicely. And this same procedure is repeated after 1 week or so. And we ask the patient that to notify us or inform us whenever there is any side effect or reactions like severe burning in urination, bleeding in the urination with urine, or fever with chills and all those. So these are signs that indicate there may be some urinary infection or severe reaction to the BCG. There is not much of discomfort, but yes, sometimes after 4 or 5 doses of BCG, some people react very badly to this medicine, and that's why whenever I start this treatment, I ask the patient to tell me whether they are tolerating it well or not. If they are not tolerating, maybe we have to stop the treatment or therapy, because for any treatment, the basic principle is the balance between the what do you call, the benefit and risk. So if there is too much of risk and less of benefit, then maybe we should not be doing that treatment. So if there is a good amount of benefit and some amount of risk, then that treatment can be continued. uh, It's usually OPD procedure, so I don't require to admit the patients for BCG. And yeah, sometimes the patient may have some mediclaim or some sort of insurance and they require admission for those procedures. But I discourage the patients to get admitted for BCG at least. Most importantly, the patient has to understand that he needs the BCG to prevent further recurrence. So the treatment has already been done by the endoscopic procedure, but now to prevent the recurrence, we are doing it. So the patient is not having any disease right now, but to prevent the risk of getting the disease back in some time, we are putting this disease. And obviously, the advantages are there. That's why we were doing it. And if we feel there is too much of side effect, we can stop it. The most important is to be under surveillance cystoscopies or cystoscopies every 3 months to know the recurrence. So if you ask me what is the chances of or what is the advantages of it or what is success rate of this therapy. So you see the bladder cancer is cancer which is known to recur or known to come back again and again, and this BCG gives me around 30 to 40% chances of risk reduction. That is, if we put we take the 100 patients, then maybe around 40 will be having a recurrent disease. That is, the chances of recurrence are there. And among those 40, if we put BCG, then they around maybe 40% or 30 to 40% will not be having recurrence of disease. So there is some advantage, and I think that's one of the most uh, extensively evaluated, time-tested medicine to prevent the recurrence. Till we have some better alternative, I think this is the best one till now. And whenever the patient can tolerate and there is no lot of logistic issues, it should be continued till the full course of protocol whatever has been given to you from your institute. uh, Thank you all for this uh, what do you call your attention, and I think I have answered whatever was in the agenda for this BCG. We'll be coming back with some more sessions on frequently asked questions that I see patients coming in my OPD about the bladder cancer in this month. And next month we'll be talking about again kidney cancer, and September is the prostate cancer awareness month, so we'll be talking about prostate cancer in that time. So I'll be happy to answer if you have any queries, or you can maybe text the questions if you have any, and then we can answer you later also. So you can watch this video later on. Mm, yeah. So there are a lot of questions which I have tried to answer. I think I think I should end this session now because I've answered all of them. Thank you all.